Okay, um, so this is a tutorial on neck lumps. Um, I'm Annabel. I'm one of the fifth year medical students. It's going to be quite a broad tutorial. Neck lumps present in lots of different conditions. So even if you haven't covered something in the tutorial, hopefully you've covered something else in another module. And hopefully I'll be able to teach you what's going on anyway if you haven't. We have a 40-year-old female who comes in with a lump on her neck. What are your differential diagnoses? And I've got a Menti. If you could scan the QR code. And give me a thumbs up once you're in. Or I can generate a code if it's not. That's no good. Okay. Fine. Brilliant. So if we're thinking about a multi-system approach using an acronym like vitamin C, what differentials can you think of? Yeah, brilliant. Goiter, um, lymph nodes, parotitis, great. So yeah, we're thinking about infectious causes, neoplastic causes. What other things can cause lymph nodes to come up? Or are there any congenital causes? Yeah, Epstein-Barr virus, brilliant. Mumps. And any vascular causes? If we're thinking about the thyroid, are there any other causes of the thyroid becoming enlarged? Okay, that's fine. We'll leave it there. So if we go through using vitamin C, under vascular, you can have a carotid aneurysm or a carotid body tumor, which is a very rare tumor. So if you're examining that, that would pulse basically. Infectious causes, so any infection can cause the lymph nodes to come up. So if you've got tonsillitis, your tonsillar lymph nodes might come up, Epstein-Barr infection or mumps. Lots of different glands can come up. Sialdinitis is when there's a stone in the salivary glands, and that can also cause a neck swelling. You can also get tuberculous infiltration of lymph nodes that causes a very big lump as well. Not commonly seen in this country, but in other countries, definitely. And you can get cysts in the neck just as anywhere else. Traumatic causes, you could have a hematoma caused by, I don't know, trauma and insect bites. Autoimmune causes, so we've got all the thyroid things going on here. So Graves' disease, Hashimoto's thyroiditis, de Quervain's thyroiditis. Metabolic causes, I don't know if it's really counted as a metabolic cause, but pharyngeal pouch is something I thought about. It's in the digestive system. So you'd feel a gurgling if you put your hand over the pharyngeal pouch. Metabolic causes can also be, they can also, so iodine deficiency can cause a goiter as well. Radiation, an iatrogenic cause can cause head and neck cancers. many neoplastic causes, so thyroid cancer, lymphadenopathy from metastasis, lymphomas, some leukemias, head and neck cancers, salivary gland tumors, lipomas, which are benign, skin cancers. Thinking about where the neck is, it's quite an exposed spot, so you might be more likely to get a skin cancer on the neck. And then congenital causes we'll go over in detail. So a cystic hygroma, a branchial cyst, and a thyroglossal cyst. Brilliant. So what questions would we like to ask this patient about their presenting complaint? Brilliant. I see you know something about thyroids. Does it move with swallowing? So yes, classically a thyroid will move up with swallowing. How long has it been enlarged for? Yes. How long has it been there for? Any fevers? Yes, very important in differentiating an infective cause from a benign cause or a neoplastic cause. Yes, painful after alcohol. Someone's done their hematology. So that's classically the case in Burkitt's lymphoma, is the neck lumps become painful after consuming alcohol. So sight, I guess we can, so if we're going through Socrates, sight, we'll probably be able to see it or feel it, so that's fine. Onset, we've covered. Character, yeah. I guess maybe we want to think about cancers. Is there anything else we want to think about? I was just thinking maybe have any new lumps come up? And yes, okay, and time, severity. So yeah, so if we're thinking about a very serious neck lump, if it's very large, we can cover this in the next question. But if we're thinking about compressive symptoms, what might you want to ask about? Yeah, weight loss, brilliant. Yeah, halitosis, thinking about the pharyngeal pouch, that's very good. T, yeah, always ask about, in any history, there'll always be questions pretty much about weight loss, fevers, night sweats, and very important in this topic as well. Okay, that's great. And one more on this. Red flag symptoms. We've covered some of them. Are there any specific to head and neck cancers that you might want to ask about? So if we're thinking about thyroid cancer, or we're thinking about nasopharyngeal cancer, or oropharyngeal cancer. Bleeding. Hoarseness, yes, that's what I was thinking of. Dysphagia, brilliant. Okay, great. So if we're going through Socrates, so we want to know the site. Anterior or posterior triangle is something we'd work out ourselves. So it's depending on the relationship to the sternocleidomastoid muscle. So we want to know when it started appearing. We want to know if it's increased in size. We want to know if there's any new lumps, any gurgling, and we want to know what it feels like. We want to know if it's tender, so when it's touched, is there any pain, tenderness, any cough or fevers, so that would suggest an infective cause. And if we're thinking about perhaps a neck lump is causing hypothyroidism, we want to ask about the hypothyroidism symptoms. So palpitations, being heat intolerant. So do you feel like when everyone else in a room is very cold, you can have a t-shirt on? If they've got any diarrhea, any weight loss, any vision changes, any palpitations. Conversely, having Hashimoto's thyroiditis, which can cause a goiter, can causes hypothyroidism. So we also want to ask about symptoms of hypothyroidism. So that can be weight gain, being cold intolerant, having cognition problems, constipation and dry skin. So what I was getting at with the red flag symptoms were, is there any pain? Is there any hoarseness? So the recurrent laryngeal nerve supplies the larynx, and in cancer, you can get palsy of this nerve. Otalgia, likewise, there's a nerve that comes from the vagus nerve, supplies the larynx, and it's also got a branch that goes to the ear. So paradoxically, it can cause referred ear pain, and dysphagia. If we're thinking about nasopharyngeal cancer, you want to ask about unilateral nosebleeds, if there's any discharge or congestion that's been lasting for a long time. Also want to ask about the generic cancer symptoms, so fevers, rigors, weight loss, night sweats, and bone pain. And bone pain, we're thinking about bone mets. And again, cranial nerve and palsies are really important. So yes, any loss of facial sensation, any weakness, any loss of taste, any tongue weakness. And then if we're thinking about any leukemias, we want to ask about recurrent infections, abnormal bruising, abnormal bleeding, bone pain, and testicular enlargement. So yes, exacerbating factors, whether they've had a viral illness recently, if there's any pain on drinking alcohol, and maybe severity, you could ask about how's it affecting you in your life. So are you having to cover it up? And has anyone else noticed it? So what examinations would you like to perform? So obviously we're going to be examining the neck lump, but what else? If we're going to be very thorough. Yes, lymph node examination, brilliant. Cranial nerve exam, perfect. Blood test, not quite yet, just examination at this stage. Yeah, thyroid exam. And if we're thinking about a head and neck cancer, is there anything else you want to examine to be very thorough? Somewhere a cancer might have originated from. We've got the neck, then we've got the all right. So yeah, I was thinking examine the neck, so the thyroid. We want to look for any signs of thyroid disease. Lymph node examination. We also want to examine the oral cavity. They might have a non-healing ulcer in their mouth that you'd want to see. Examine their ears, check there's no cancer in there. And cranial nerve exam, we said. So I'm going to go over how we examine mostly the thyroid, but also I'll cover how to properly examine the lymph nodes. So I'm sure you've all been taught to examine the thyroid, but I still like to remember how to do it with IPA. So inspection, we'll want to look at the patient's clothing, their body habitus, what are they sweating? Are they looking cold? You want to look at the hands. So I find it's good to sort of go from the hands and then like upwards, basically. So hands, so I look for any oncholysis, so any splitting of the nails from the nail bed, any palmar erythema, so any redness in the palms. Because I'm on the hands, I'll then like to feel the pulse. Then also because I'm on the hands, I'll check for a tremor. And the way you do that, you use a sheet of paper and you place it on the hands. And that exaggerates a tremor, but it doesn't exaggerate it, but you're able to see it better. And then moving up, you'll look at the eyes. So have they got very widened eyes? Is there any eyelid retraction? Does it look like their eyelids are sort of sticking out of their eyes? So that'd be proptosis. What does their skin look like? So if they've got hypothyroidism, their skin might look very dry. The classic one you look for in hypothyroidism as well is the outer third of the eyebrows is lost. And then you'd also look at the legs for any pretibial myxedema. Then moving on to the neck itself. So you'd look at the neck from the front, like looking at the size, where it is. And then you stand behind the patient when you're examining, and you use the pads of your fingers rather than the tips, because you've got a lot more sensation on the pads of your fingers. So you palpate the thyroid isthmus. So that's, I don't know if it's helpful for you to do it with me, but if we go from the thyroid cartilage, so that's the Adam's apple, and then you go down, and the cartilage that you can feel under that is the cricoid cartilage, and then you want to feel the second and third cartilage below that, and that's where the isthmus is. So that's the lobe that the part that connects the two lobes, and then you want to feel out from there, and that's where the thyroid is. And if you swallow now, you should be able to feel that rise. So while you're doing that, you should be feeling for the consistency, whether there's any nodules, and noting the size of the thyroid. Just to note that a normal thyroid, you shouldn't be able to see just looking at the patient. And then you'd ask the patient to take a sip of water, and you'd feel the thyroid rise. And then you'd ask the patient to protrude their tongue while still palpating the thyroid gland. And a thyroid wouldn't rise when the tongue is protruded, but a thyroglosal cyst would rise. And then if we're looking at percussion now, sorry, it's not quite in order, but you percuss the thyroid. So really big goiters, they actually go below the rib cage. So you'd want to feel the lowest edge. And then really hypervascular thyroids that have been very stimulated, you can actually hear the sound of blood flowing through them. So you'd want to listen out for the blood going through them. And then it's also very important to do a systematic lymph node exam. So you use, again, the pads, and you use one hand at a time using your second, third, and fourth fingers. And you don't just prod it, you sort of roll your fingers either side the lymph nodes. So I have a lymph node that is always up, and I can sort of feel it moving around here. So you want to sort of roll it between your fingers. And you want to note whether it's what the size is, whether it's firm or soft or rubbery or irregular. You want to know if the patient feels like pain or if it's tender when you touch it. and whether it's mobile or if it's fixed in place. Also, in a thyroid exam, you'd want to check for peripheral, myopathy. So in hyperthyroidism, you get wasting of the muscles, so they find it hard to get up from chairs. And then you also get evidence of, you want to check for evidence of tracheal deviation. So a large thyroid can cause tracheal deviation. You also want to check reflexes. In hyperthyroidism, the reflexes are reduced. So yeah, I've got a nice picture of the thyroid here, which I found quite useful. Great. So next, I've got to sort of pin the tail on the donkey thing. So this is a not great image, but I've tried to illustrate that there's a central area, and then there's an area that goes up and down, and then I've got the anterior and posterior triangles of the neck, and the circles are supposed to represent lymph nodes. So could you tell me can you pin the spot on the neck where a thyroglossal cyst would most likely appear? That working? Yeah, brilliant. Yeah, so thyroglossal cysts are central. They can be anywhere up and down the neck. They'd be above the thyroid, but yeah, anywhere up to, yeah, right at the top. There's places where it's more common to have them, but yeah, just if you just remember anywhere up and down. And the next one is, where would a cystic hygroma most likely appear? Anyone else? It's okay if you don't know. I didn't know this. So cystic hygromas are from malformations of the lymphatic system. So it's congenital. It normally presents at birth. And actually, the most common place to have it is on the left side. So yeah, good job about that. And it's more commonly in the posterior triangle. And where would cancers from the head and neck most likely metastasize? Okay, got someone sitting in the middle. Okay. So this box is sort of supposed to represent the thyroid gland. So it's not inconceivable, but mostly they metastasize to the anterior triangle. So either side, yeah. Great. So yeah, this is a very basic diagram, but in the middle, we've got the thyroid. So a goiter you can have in the middle, which would be smooth. Thyroid nodules would be a single lump, and thyroiditis, so inflammation of the thyroid, is tender. If you were to have metastatic cancer, it's most common in the anterior triangle of the neck, and you'd have a fixed and firm and irregular lymph node. Lymphoma is typically described as rubbery. Again, that can be anywhere. if you get it in the posterior triangle, it's probably slightly more like, well, it's less likely to be from metastatic cancer. It's more likely to be another cause. So lymphoma is a good one. And then a reactive lymph node would be tender and it's small. And then, as everyone correctly said, a thyroglossal cyst is central and it rises on tongue protrusion and swallowing. So it's a remnant of the thyroglossal duct that was used to pull, during embryological development, was used to pull down the thyroid gland from the base of the tongue to where it sits at the moment. And then sometimes it just doesn't close up properly. So you get a cyst forming. So yeah, it can be anywhere along there. A branchial cyst is normally in the anterior triangle or like just above the sternocleidomastoid. And that's from incomplete development, incomplete closure of the branchial clefts. Again, embryology. I'm sure we all love that. And then the cystic hygroma, as I explained before, is from incomplete lymphatic formation. And just because of how it forms in the body, I'm not completely sure of the reason why, but it's more likely to form on the left. So yeah, if we've gone through most of these. Metastatic cancer, if we're thinking about demographics, it's often older people, smokers, HPV positive, and people that are HPV positive. So yes, and then lymphomas, typically seen in elderly people. You'd expect some other symptoms like weight loss and fever. The thyroglossal cyst can be anywhere. It's typically seen in young, it presents, it's more likely to present in younger patients. So people that are younger than 20. But I know my uncle had one and he presented in his 50s. So that's not necessarily the case. And there's the male and female ratio is the same. They can become infected, so you can get skin redness and tenderness, and they can also become open to the air, so you can get sinus tracts causing them to become open to the air. The branchial cyst is unilateral, anterior to the sternocleidomastoid muscle, and it usually presents by early adulthood. They're often oval. They're mobile and they're fluctuant. They again can become infected and form sinus tracts so that they're open to the air. And they can get quite large and they can cause airway obstruction. Cystic hygromas are from, malformation of lymphatic ducts, classically found in the axilla or the posterior neck triangle. And generally, if you get a child that's below 2 years old in a question, it's a cystic hygroma. It's also associated with some genital conditions. For example, patients with Turner's are more likely, there's an association with that and cystic hygromas. So the important thing about cystic hygromas is that they transilluminate. So when you shine a light through them, you can sort of see inside, it sort of glows. And that's because they're full of lymph and they're quite close to the surface. So they're soft and they're painless, and they're fluctuants. That means it feels like there's liquid inside. And again, they can be quite large and cause airway obstruction. So this first picture is a thyroglossal cyst. So you can see that's in the midline. And then this one is a branchial cyst. So that's that side. And this is a cystic hygroma, again, seen in a child. That's quite a big one. So with this 40-year-old lady, you notice a central neck mass, which is non-tender and smooth. It rises on swallowing, but not on tongue protrusion. She seems agitated and she's noticed recent weight loss. And you see the following signs. So on her hands, she's got redness of her hands, palmar erythema, and she's sweaty. She's got a fine tremor. So when you do the paper test, it flaps. She's got an irregular pulse. When you examine her eyes, you can see that there's proptosis. She's got pain and double vision on eye movements, and there's lid lag. I should have mentioned earlier about examining the eyes, actually. That's quite an important part of it. So you want to do, I don't know if you've done cranial nerve exams yet, but you want to do like the H test. And you want to do it very slowly, especially when you're going downwards, you want to go very slowly. So you want to see that the eyelid lags behind the eyeball. That's what lid lag means. And proptosis is when, so normally the eyelid sits just below the iris, but in proptosis it sits above. So it's quite subtle in some people, but you probably will start noticing it more. So this, can anyone name this sign? This sign, eye sign. Okay, exophthalmos. Yeah, so proptosis is when the eye sort of sticks out of the eyeball, which I guess it could be. You generally examine that from like the top of the head. Um, this is actually eyelid retraction. So the other option, yeah, exophthalmos, that's the same thing, I think. So yeah, proptosis, they're the same, yeah, synonyms. So this is eyelid retraction. So actually, this is what I was explaining earlier. Sorry if I confuse anyone. This is when the iris, there's a gap between the iris and the eyelid. So you can see there's white in between. And you can see that on the top and the bottom eyelid of the right eye. And then what's this leg sign? Oh, sorry. So the leg sign. Yeah, exactly. Pre-tibial myxedema. Great. So yeah, it's just a sort of inflammation of the lower legs. I think it's quite rare actually, but a classic one. So given all these signs, what do we think that this patient is suffering from? Oh dear, I'm sorry, giving it away. Uh, yeah, brilliant. Graves' disease. Um, yeah, so she has signs of hyperthyroidism, but she's got signs that are specific to Graves' disease. So the tremor and the eye signs are specific to Graves' disease. So I'll go over hyperthyroidism signs. So the thyroid hormone basically speeds up metabolism. So I like to remember that, and then it helps me think of the symptoms. So it causes agitation and restlessness. It causes weight loss, causes heat intolerance. If you're thinking someone's like on the go all the time, they're like creating a lot of heat. So they don't like being in hot environments. Um, it just speeds up the digestive tract as well, so they have diarrhea. It causes heart problems. They can get a very fast pulse, and they can get atrial fibrillation with it as well. And particularly important for next year, it can cause infertility and oligomenorrhea, so no periods or like irregular periods. Um, so that's one to ask that people often forget about. Um, so, and hypothyroidism can also cause a goiter. And thinking about the feeling, what the goiter feels like or how it is. So in thyroiditis, the goiter is tender. In Graves, it's non-tender and it's smooth. And in toxic multinodular goiter, it's very big and it's got an irregular consistency. And then a toxic or a non-toxic adenoma would feel like a single lump in the thyroid. So Graves' disease causes most of the hypothyroidism cases. It's quite common. It's seen in 0.5% of the population, and it's more common in females than males. And the most common age group is 40 to 60-year-olds. And triggers include stress, childbirth, and infection. So specific signs include thyroid acropaxy, which is when the nail separates from the nail bed, and then oncolysis, which is when the nail just splits. Thyroid eye disease. So it's seen in 50% of Graves' disease. So exophthalmos, it's when the eyes pop out, and you look from above. So the top picture, so you can see that the eyes are sort of popping out of the eye, out of the skull, basically. There's so much swelling behind the eye that they sort of stick out. It causes double vision, and that's because of rectus muscle palsies from the swelling. So when you're doing the H test, you want to ask the patients if they see any double vision or any pain. It can cause corneal ulceration, loss of acuity, and loss of color vision if the optic nerve is compressed by the swelling behind the eye. And it can also cause dryness. So, and in Graves' disease, you also have a smooth goiter, and another specific sign is the pretibial myxedema. You can also get red eyes. So chemosis is inflammation of the conjunctiva, and puffy eyes as well. So on the eye, above the eyes and below the eyes, and puffy eyelids. And other causes of neck lump are toxic multinodular goiter. So you get a very large goiter with multiple nodules, and these have autonomously functioning nodules. So they're not receptive to the negative feedback system. So they're producing a load of thyroid hormone, but and in response to that, the TSH will be going down. So it's going to be saying, no, stop. There's enough thyroid hormone, but they're not responsive to the lack of TSH. Because the goiter in not toxic multinodular goiter can be so big, it can cause dysphagia and shortness of breath. And this is most common in over 50s and people that are iodine deficient. So in some places of the world, there's shortage of iodine in water and other sources. So in mountainous regions specifically. And in toxic adenoma, you get a single nodule in the thyroid that, again, autonomously produces thyroid hormone, but this time it's just a single nodule. And that's more common with increasing age and iodine deficiency again. So thyroiditis causes, so de Quervain, it's also called subacute thyroiditis. It causes initially hyperthyroidism and then hypothyroidism and then euthyroidism. So the thyroid hormones recover to a normal level. Sometimes actually the thyroid gland can be damaged by the inflammation and they stay hypothyroid. So this typically causes a painful goiter, but it's normally self-limiting. And in the history, you might discover that they've had a viral illness just before. Hashimoto's thyroiditis actually causes hypothyroidism. So going to list some symptoms of hypothyroidism. Well, we've done this before, but weight gain, dry skin, constipation, just to name a couple. And then, yeah, cognitive impairment and things like that. So Hashimoto's actually has a non-tender goiter, but it's very firm. And it's associated with other autoimmune conditions such as vitiligo, celiac disease, type 1 diabetes. So you suspect Graves' disease. Which blood test results would be consistent with this diagnosis? Sorry, it's quite a lot of words. It takes a while to read, don't worry. So we've mentioned that Graves' disease causes hyperthyroidism. So you can rule out the low T3 and T4. And then we've talked about negative feedback. So if there was high T3 and T4, you get a low TSH. And then, does anyone know what causes Graves' disease? That's okay if not. So the answer's this one. So in Graves' disease, you have antibodies that stimulate the thyroid gland. So they stimulate the thyroid gland receptor. So they're acting like TSH, but they're not TSH. So you're having high thyroid hormones, so high T3 and T4. There's two thyroid hormones. T4 is produced first, I believe, and then it gets converted to T3. I might not be quite right, but T3 is the active thyroid hormone. And because there's negative feedback, you get low TSH. So the thyroid gland's going, no, we've got enough thyroid hormone. And then it's the brain's going, we've got enough thyroid hormone. I'm not going to produce any thyroid stimulating hormone. So that goes down. But because there's thyrotropin receptor antibodies, you still get the high thyroid hormone. So investigations that you'd want to do in someone with a goiter. So you'd want to do thyroid function tests. And in hyperthyroidism and hypothyroidism, they're sort of inverse of each other, which makes sense. The antibodies you need to know are the anti-thyroid stimulating hormone receptor antibodies are positive in Graves' disease. There's positive anti-thyroid peroxidase hormone antibodies in Hashimoto's disease, and the antithyroglobulin and thyroid peroxidase antibodies are actually quite non-specific, so you don't really rely on them very much, but they're always present in Hashimoto's disease, or often present in Hashimoto's disease. Yeah, so you get increased thyroglobulin levels in lots of different disorders, including thyroiditis and thyroid cancer. It's actually used to measure response to treatment in thyroid cancer. And then if you're suspecting medullary thyroid cancer, which we'll cover, you'd want to do tests for calcitonin. And you might also want to do thyroid scintigraphy. So I've got some pictures here of thyroid scintigraphy. So the first one on the top one on the left shows diffuse increased uptake. So it's a very hot thyroid gland. So that would be the case in Graves' disease. And then if we go right, this shows there's sort of patchy uptake, but it's increased iodine uptake. So that's the case in toxic multinodular goiter. And then if we're going clockwise, we've got one hot nodule here, so that would be a toxic adenoma. So toxic versus non-toxic adenomas, I don't know if I explained at the start. Toxic's the one that's producing thyroid hormone, causing problems. Non-toxic adenomas is just a lump. It's not doing much, it's sitting there. And then, the one on the left, that could be, so that's reduced uptake of iodine. So that could be the case in Hashimoto's or subacute thyroiditis. So this lady states she hasn't got any medical history. She's got these observations. What medication should she be given? Or what's the next step? Does anyone want to share why they've put those? Oh, I'm sorry, I've just seen the chat. Okay, I'll answer these at the end. Okay. So yeah. So the treatment for hypothyroidism, generally you want to go with a pharmacological option first. So the first pharmacological option, first line, is carbimazole, actually. This inhibits thyroid peroxidase. So this is an enzyme that adds iodine to thyroglobulin and makes it into the active hormone. And you'd avoid this in the first trimester of pregnancy. I'm not sure what that last point was, but there's a pancreatitis risk. And then the other option that you can do is propylthiouracil, which acts quite similarly. It's got a more rapid onset of effect. You'd avoid this in the second and third trimesters of pregnancy. But it can cause liver reactions, which is a small risk, but it's the reason it's actually second line. So in this lady, we would be giving carbimazole. And there's two sort of regimes that you can do to give these medications. So you can block and replace. That means you sort of wipe out all thyroid hormone production and then add levothyroxine on top of that. So it's a bit of a guess initially, but you're like whacking them with a huge dose of carbimazole and then giving them some levothyroxine. Or you can do a titration. So you can give them carbimazole and then increase their thyroid hormone so that it's at a normal level. So it's more of a gradual, so you like do this basically, if that makes sense. And both of these medications can cause agranulocytosis. So if in a question you have someone that's just been started on carbimazole and they turn up to A&E and they've got a cough and they're a bit sneezy, you want to do a blood test because it can cause agranulocytosis. So you want to do a full blood count for that. Another thing I want to mention is if they've got any cardiovascular effects, so if they've got atrial fibrillation or they've got a very high heart rate, you want to give them propranolol. And a thing that questions like to do is to catch you out with asthma. So if you've got asthma, you can't give them a beta blocker. So you can use nebivolol if they've got stable asthma. But if it's very unstable asthma, you want to give them diltiazem because that's not a beta blocker at all. And you can also use digoxin. Other treatments are radioiodine, which is a definitive treatment. You generally give that to older people, so over 40s, because of the risk of thyroid cancer in younger patients. And you do this especially for toxic multinodular goiter and adenomas. But because it's definitive, it stops, it causes hypothyroidism. And you wouldn't want to do it if you were pregnant or trying to get pregnant because it can cause congenital defects. And yeah, you wouldn't want to be around children. And then another definitive management is surgery if they're unable to take any medications or radioiodine. And this is when you take Lugol's iodine. So Lugol's iodine actually causes hyperthyroidism, but that increases like uptake. So I think it's so that they can see the thyroid gland when they're operating or something like that. And yes, that would then cause hypothyroidism. Another thing you want to know about is the thyrotoxic storm. So if you've got so much thyroid hormone going around, it can cause agitation, restlessness, tachycardia, fever, high output heart failure, and delirium and altered mental status. And yes, so you'd use propranolol and digoxin for heart symptoms. You'd use propylthiouracil and Lugol's iodine through an NG tube to reduce thyroid hormone. Corticosteroids reduce peripheral conversion of T3 to T4, T4 to T3. So remembering T3 is the active hormone, so you want to reduce the active hormone, and then IV fluids as well would give them. So this is the second case. A 65-year-old woman presents to the GP practice complaining of a neck lump. She noticed it 2 weeks ago, and she thinks it's got bigger over the last week. She thinks maybe it was related to a recent cold. She has a past medical history of Hashimoto's thyroiditis. Her partner also thinks her voice has become huskier recently. The lump is just to the left of the second tracheal cartilage. It's firm, it's non-mobile, and it's not painful. In the Menti, could you write down the risk factors that are present here and which features make you suspicious of cancer? I'll just leave it on here. Quite a big paragraph. Yeah, brilliant. onset 2 weeks. Yeah, it's grown. Yeah, she's in the right age group to have something neoplastic going on. Anything about the consistency of the lump that makes you worried? Okay. So the things I thought were important were that, yeah, she's in the right age group. Um, she's a woman. So if we're thinking about um, thyroid cancer is more common in women. Um, she thinks it's got bigger. She's got a past history of thyroid disease, so thyroiditis, and that actually increases your chance of getting a thyroid cancer. She's had a voice change, not necessarily relevant actually in this case. So it is one of the red flags. She has had a cold, so it could be some laryngitis, but again, it's something we worry about. And if we're thinking about where the lump is, it's where the thyroid is. So just to the left of the second tracheal cartilage. The thing I was wanting to hear about was the fact it's firm and it's not mobile. So yeah, that's what I thought. So thyroid cancer risk factors are female sex, obesity, having a previous benign thyroid disease, if they've been exposed to radiation, having lupus, or having a family history of thyroid cancer. And these are the red flag symptoms you want to ask someone when they come in with a lump on their thyroid. So hoarseness or voice changes, lymphadenopathy, and if it's a sudden onset, if it's painless, or if it's expanding, and if they've got any compressive symptoms such as difficulty swallowing, pain swallowing, or shortness of breath. And this is when you want to refer them on to a 2-week wait service. So which investigations would you want to order for her? So we can start with the ones from before as well. So bloods, what kind of bloods would you like? Yeah, bloods, brilliant. Thyroid function tests, thyroid scan. What kind of scan does that mean? So we're right about the thyroid scan. We do want to look at it. And the way we do that is ultrasound. Do you want to biopsy it as well, maybe? Okay. So yes, bloods, thyroid function tests, very important. Thyroid cancer is mostly euthyroid, so it doesn't cause any changes in levels of thyroid hormone. But later stages can cause gland destruction and hypothyroidism. We want to rule out any benign disease. So we want to check the thyroid autoantibodies. They're also present sometimes in cancer. Medullary thyroid cancer can be caused by this condition called MEN. So it's multiple endocrine neoplasia. So if you're suspicious of that, if there's a history of that, or they've got pheochromocytoma, they've got you can learn about this separately. It's a bit of a thing in itself, but yeah, you'd order CEA and calcitonin. The investigation of choice, generally in neck lumps, is an ultrasound, and that the results of the ultrasound determine the risk of malignancy and whether a, a biopsy is needed, basically. So if they think it is needed, they'd use a fine needle aspiration to get a cytology sample. And then based on the sample, it's given a thigh rating. So thigh 1 is when I think it's an inadequate sample. Thigh 2 is when they think there's nothing wrong. And then I think that might be wrong, but I think thigh 3 and 3 to 5, you definitely want to do something about it in terms of getting the cancer out, or at least getting a further biopsy. And then based on that results, you might want to do further imaging, such as a CT or an MRI. You might also want to do radioactive iodine uptake. So if we go over some thyroid cancers, the most common thyroid cancer is papillary thyroid cancer. This is a question they love to ask. I think of it as papillary as popular. It actually presents in quite young people. So I saw a lady with it, and I think she was 34, which I found quite shocking. Generally in very fit people. So the risk factors are radiation, and it presents as solitary painless thyroid nodules. It metastasizes via cervical lymph nodes. So you want to feel also if there's any other lymph nodes that are up. Histology, generally, I'd say is not worth learning, except for some things, but I thought they were quite nice features that you could pick out in papillary thyroid cancer. So the first are the orphan Annie cells. So I believe the orphan Annie cells are supposed to look like the eyes of orphan Annie. So I don't know if you can see that. And then the Samoma bodies are like these whorls, which are quite pretty. So if you can see that in a sample, then it's probably papillary thyroid cancer. It's got a very good 10-year survival, and the treatment would be a lobectomy or a thyroidectomy with a neck dissection if there's any lymph nodes involved, and then you give post-op radioiodine. Follicular thyroid cancer is the second most common type. This normally presents in older age groups, and the risk factors for this are iodine deficiency. It spreads by the blood, so it can go to the bone or the brain or the lung or the liver, and it presents as a slowly enlarging nodule. The survival rate's not quite as good, so it's a 92% 10-year survival, and you do the same treatment as with papillary thyroid cancer. And yes, you monitor treatment response using thyroglobulin for both of these cancers. But medullary thyroid cancer is a cancer of the parafollicular cells of the thyroid. So these are the C cells, and they produce calcitonin, which regulates calcium in the body. So yes, if you're suspecting this, you want to check calcitonin levels. This is 5% of thyroid cancers, and 20% are inherited. So you can get familial medullary thyroid cancer, men 2A and men 2B. And yeah, as well as normal investigations, you want to do calcitonin and CEA and a urine sample to assess for pheochromocytoma. Again, you'd perform surgery on these patients, but because it's the cell doesn't have any iodine uptake, it's involved in calcium regulation. Radioiodine doesn't work, so you wouldn't do radioiodine. And then anaplastic thyroid cancer is uncommon, and it mostly affects the very elderly. Generally, it's someone that's above 80. And it presents as a rapidly enlarging, bulky neck mass. It's got a very poor prognosis. So generally, they wouldn't last long enough to do any treatments, and it would be palliative care, unfortunately. So a couple more SBAs to tie some things up. This is a bit of revision. Nearly finished. I think it's just 5 more questions. Okay. I'll switch back for the question. If you don't know, just give it a guess. So it's painless neck lump, slowly enlarging. Just had a cold. No night sweats or weight loss. The lump moves easily, so that might help you discount some things. It's soft. It doesn't transilluminate. It doesn't move on tongue protrusion or on swallowing. Okay, brilliant. Thyroglosal cyst. Yes, so right. Come on. So I think actually the answer is a branchial cyst. If we remember that the thyroglossal cyst, it's where the thyroid gland moved down centrally to where it is now. So it's in the center. And this is in the anterior triangle of the neck. So that's what points you away from the thyroglossal cyst. If we go through the other options, the dermoid cyst, firstly, we haven't talked about it. Secondly, it can be like a collection of like epithelial tissues. Sometimes it can contain like teeth, nails, and things like that. So that would be a very hard lump, and this is a soft lump. Sialolithiasis, that's when there's a stone in the salivary gland, and that can cause pain on and off with like chewing and things like that. And it seems to be in the wrong area. So you'd get this in salivary glands, and this is in the anterior triangle of the neck. Thyroglossal cyst. So the fact that it's come up in after a cold does suggest it might be some kind of congenital thing. But yeah, it's not in the center. A lymphoma would have the classic, like it's rubbery, feels rubbery, it doesn't move. So this is a branchial cyst. So it's presented in someone that's quite young, but not very young. It's soft. It's not connected to the thyroid at all. So it doesn't move up on tongue protrusion or swallowing. So yeah, no thyroid involvement there. Okay. Does that make sense? Okay, great. So next one is a 12-year-old boy presents with painless fluctuant midline mass that moves up on swallowing and with tongue protrusion. The mass is just below the hyoid bone, and it's been present for a few months. What should you do about it? I didn't really cover. Yes, exactly. Yeah, great. So yeah, the definitive treatment for any congenital lump is surgical excision. Um, so you want to firstly make sure that it's not anything concerning. So you do an ultrasound, and you might want to do a biopsy or a fine needle aspiration cytology. Um, and yes, once you've confirmed that it's nothing concerning, you then would excise it. And the reason you excise it rather than leave it in place is that you can get recurrent infections if it's left there. So the cyst trunk is the procedure they use for thyroglossal cysts, and that's when they remove the cyst and they remove the tract, and then they also remove. So it's part of the thyroglossal duct. They remove the thyroglossal duct if it's left, and part of the hyoid bone to stop it recurring. Um, it's very similar managements of the other congenital neck lumps, so surgical excision. And you can also use sclerotherapy, which is when there's a fibrosing agent introduced to the cyst, if surgical excision isn't appropriate. And then a cystic hygroma, yeah, they only require treatment if symptomatic, but you can excise them because sometimes they could be quite big, or use sclerotherapy. So the next question is a 58-year-old lorry driver presents with a lump in his neck. He noticed it after recovering from a cold. There's no change in size. He's well. No red flag symptoms. He's a smoker. He drinks. And worryingly, it's a hard fixed lump in the anterior triangle of his neck. So what should we do to investigate? Next. So the first thing you do. Also very important to read the question. If it's the next best investigation or the definitive treatment, it trips me up. Yeah, brilliant. Ultrasound neck. So for neck lumps, ultrasound is the best option for investigations. For cervical lymphadenopathy, things that you do before that, you could do some bloods if infections are suspected. Also, if we're worrying about leukemia, lymphoma, also a good idea to do bloods. Ultrasound is great for neck lumps because they're very visible under ultrasound and it's very non-invasive. And then you'd use fine needle aspiration cytology. However, if lymphomas is suspected, you do a core or open excision biopsy instead of a fine needle aspiration cytology. And then, yes, you'd manage based on results. So you could go on to do some staging if it does turn out to be malignant. So this one's a bit different. 4-year-old child presents with fatigue, pallor, recurrent infections over 3 months. There's cervical lymphadenopathy. And there's low hemoglobin, low white cells, and low platelets. So what's the most likely diagnosis? Okay. So if we go through the options, tonsillitis, I'm thinking it's a bit more worrying than tonsillitis. They've got pancytopenia, and it's been going on for 3 months. Lymphoma, I think the recurrent infections, the pallor and the fatigue, and also the pancytopenia make this a bit less likely. Also, it's a 4-year-old child. Lymphoma is normally in older people, is often a disease of, yeah, older people. So AML, again, that's a disease of older people. The most common leukemia in children is acute lymphocytic leukemia. So that's the correct answer. And it causes pancytopenia and lymphadenopathy. So the other option, maybe I thought perhaps it'd be a bit mean to add on the question, would be CLL, which because it's lymphocytic, it can also cause lymphadenopathy. So if you remember that lymphocytic leukemias cause lymphadenopathy, that might help, or are more commonly associated with lymphadenopathy. But yeah, well done. And the next question, I think this is the last question. A 42-year-old man presents to ENT with a neck lump. He's got some risk factors. The lump's below his earlobe. So it seems to be in the anterior triangle. He's got a squamous cell carcinoma. What's the most likely primary site? Oh dear, sorry. This is a bit difficult, don't worry. Okay, thyroid. Okay, thyroid. So, thyroid cancers don't very, very uncommonly cause a squamous cell carcinoma. So it's very unlikely to be that. The P16 positive, that's indicating that the cancer is caused by HPV. So HPV 16, I think. Oh, no, it's not. It's not. It's a mutation. But yes, if we're thinking about risk factors, he smokes, he drinks alcohol and he smokes. Oral, I think this was wrong actually. I think it was HPV positive. So oral cancer, uh, yeah, so anything in the oral cavity is commonly a squamous cell carcinoma. And so given the fact that this is a bad question, I'll forgive everyone. So HPV positive cancers are commonly, so it's nasopharyngeal cancer, sorry, or oropharyngeal cancer, are commonly HPV positive. So this difficult one and bad question, I'm sorry about that. So red flags for head and neck cancers are for laryngeal cancer, unexplained hoarseness, an unexplained lump, and the risk factors for this are smoking and alcohol, oral cancer, a lump on the lip, erythroplakia or leukoplakia, an unexplained ulceration in the oral cavity. So I think someone was asking earlier, a non-healing ulcer indicate. What does a non-healing ulcer indicate? And it would indicate oral cancer. So sorry, I didn't see that. And yeah, risk factors for this are smoking and alcohol. Anything in the sort of gastrointestinal system, like the upper GI, most commonly causes squamous cell carcinoma. That's the question they like to ask. And I also think about, where does alcohol move? So it goes from the mouth, so it can cause mouth cancer. If we're thinking that alcohol is a carcinogen, it goes down the pharynx, and then it goes down the esophagus, and then it goes, and it causes liver cancer and everything. So yeah, just think about where it moves. Nasopharyngeal cancer, you worry about a unilateral conductive hearing loss and a neck clump. Salivary gland tumors very commonly cause nerve palsies. You worry if you've got a nerve palsy and a lump. So the most common tumor in a salivary gland is actually a benign tumor called a pleomorphic adenoma. But if it's causing any palsies, you worry about it being a carcinoma. And if they're a smoker and they're older, it's commonly a Warthin's tumor in questions. And all of these would prompt referral to a specialist centre under a 2-week wait pathway. Okay, so that's the end of the tutorial. Thank you for staying with me. So in summary, we've talked about clinical examinations and histories and the importance of them. A big point to take home is where a lump is and how that indicates what it is. Thyroids rise on swallowing, but not on tongue protrusion. We've talked about hyperthyroidism and causes of hyperthyroidism. And we've learned about the location of lymph nodes. I'd also recommend that you feel some lymph nodes on healthy patients and patients with cancer. Try and feel what a normal node feels like and what an abnormal node feels like. Very important for clinical practice. We've also covered congenital neck lumps and red flags for head and neck cancers. So brilliant. Thank you very much for staying with me. Do you have any questions? And it'd be great if you could fill in the feedback form. I'll just go over the last question because it's bugging me. Yeah, so this was about it being, it was about it being HPV driven. So oropharyngeal cancer is commonly driven by HPV. So that makes it the right answer. And yeah, nasopharyngeal is associated with EBV. Sorry, I got tired at the end there. Okay, I'll stop recording now if anyone has any questions.